Hello everyone, I am Mary. Today our group is representing MedCall4. I am starting presentation by discussing the high priority clinical manifestation based upon A to Z assessment of Miss Casey. So number one is hypotension and inadequate tissue perfusion. Well, Miss Casey is indicating hypotension and poor peripheral perfusion, which are signs of circulatory compromise caused by septic shock leading to higher mortality. To address hemodynamic instability, immediate action and additional examination are required. Second one is altered mental status and confusion. Miss Casey GCS is 14 and she is confused and not oriented to time, place, or person, which indicates cerebral hypoperfusion caused by hypotension or metabolic disorders such as diabetic ketoacidosis. To avoid future neurological degeneration, it is critical to evaluate and manage the underlying cause as soon as possible. Third one is metabolic derangement. Elevated body temperature of Miss Casey, sign of metabolic acidosis, high lactate and blood glucose levels, including ketones, are consistent with the presence of moderate diabetic ketoacidosis. The metabolic imbalance may increase the circulatory impairment and neurological symptoms which impact human body negatively. To address the acid-base imbalance and metabolic abnormalities, immediate intervention needs to be taken. And last one is signs of a potential post-operative infection. Open palpitation, Miss Casey complains lower abdominal crampy pain, increased urine frequency, and a soft and painful lower abdomen. Laparoscopic site erythema indicates possible surgical site infection. Elevated white blood cell count and C-reactive protein levels indicate an inflammatory response. To address the suspected infectious cause and avoid future complications, immediate examination and intervention are required. These are some significant concerning issues which leads for initiating the medical for Miss Casey. For further discussion, I would like to invite my friend Bruna. Thank you.
Thanks, Mary. My name is Bruna, and I'm going to describe the pathophysiological link to the identified high-priority clinical manifestations of diabetic ketoacidosis. Miss Casey's clinical manifestations of DKA are diarrhea, vomiting. She is constantly nauseated, has increasing lethargy, lower abdominal pain, increased urinary frequency, polyuria, hypotension, altered level of consciousness. When diabetic ketoacidosis occurs, tissues are unable to use glucose due to the lack of insulin. This increased glucose levels in the blood, hyperglycemia, which can be seen in her blood and urine as her BGL is high and there is glucose in her urine. When this glucose is unable to move to the cells, then this excess glucose will enter the renal tube, increasing the osmotic pressure, and the person will have more frequent urination. This will result in the loss of large amounts of fluid and electrolytes, causing dehydration. Then the sympathetic nervous system will respond to the need for glucose and convert the glycogen into glucose by producing extra glucose in the body. When the glucose is not unable to move in the cells, then the liver will burn fats and protein to form the energy to the body. The burning of fat and protein will produce ketoacidic substances such as acetoacetate and acetone, which causes metabolic acidosis. The increasing number of ketones in blood will imbalance the various electrolytes, will lower the blood pH and bicarbonate. When there are high ketones in the body, then it will act on the area postrema, which is located in the medulla oblongata of the brain, and the chemoreceptors detect emetic agents, toxins, and pathogens in the blood, and will supply the information to the vomiting center and cause nausea and vomiting to the patient, which are some of her clinical features. The release of protons in the body will make more acidosis. This results in the movement of protons from extracellular space to the intracellular space. The cells will push potassium out with each proton that will enter the cells. The body will lack potassium, which results in arrhythmia in the patient. In Mrs. Casey, she presents with bradycardia, low heart rate. When a patient is dehydrated, then the blood pressure will drop and stimulate the baroreceptors and sympathetic nervous system, and it will lead to vasoconstriction. Summarize, Mrs. Casey is presenting lethargy because glucose is unable to enter the cells and give her energy, ATP, due to the lack of insulin. The increase of body ketones in the blood will make her vomit, have diarrhea and polyuria, which are the compensatory mechanisms to overcome acidosis. Then she will have dehydration with the loss of fluids, and her blood volume will decrease, with consequently will decrease her blood pressure. The electrolytes imbalance will affect her heart rate. Abdominal pain and tenderness are due to metabolic acidosis, and altered states of consciousness are due to the severity of hyperglycemia and electrolyte disturbances. My part is finished here. Now I'm passing it to Deepika.
I just want to make sure my mute is on. Thank you, Bruna. I'm Deepika Patrai. I'll talk about the pathophysiological link between the multiple disease condition that deteriorating patient Miss Casey has and the clinical presentation. According to the case study, Miss Casey is deteriorating, has multiple diseases such as type 1 diabetes mellitus, DKA diabetes ketoacidosis, endometriosis, and post-operative infection, which contributes to the clinical presentation. The pathophysiological link between the various diseases and condition of this deteriorating patient is type 1 diabetes, diabetes ketoacidosis, and post-operative infection. Type 1 diabetes is a condition where there is not enough insulin production by the pancreas in the body. The cells are not able to use the glucose from the bloodstream due to the deficiency of insulin that contributes to the hyperglycemia. When the glucose cannot move into the cell, the liver burns the fat and protein to form the energy. The burning of fat and proteins by the body for energy will produce ketoacidic substances, which causes metabolic acidosis. This results in diabetic ketoacidosis, DKA, which the patient has in the case study. According to the case study mentioned, the deteriorating patient had laparoscopy surgery for endometriosis a week ago. It is expected to have a post-operative infection in the patient who has a surgery. It was highlighted that the patient has erythema on the laparoscopic site, which is possible sign of infection. It is known that DKA can be triggered for two reasons. When there is decreased insulin, for instance, type 1 diabetes, or sometimes increased insulin demand, which can be from the infection, inflammation, intoxication, and iatrogenic. The clinical manifestation that Miss Casey presents with fever may be a sign of her body inflammation, which can be seen in her laparoscopic site. Erythematous. She has abdominal pain, and it can be seen in her blood results, which with elevated white blood cell, 17.4 times 10 per liter, when the normal number of white blood cell in blood is 4.5. Additionally, her C-reactive protein is 25 mg per liter, which is a sign of inflammation. The normal is less than 0.5 mg per liter. If it is elevated more than, it is a sign of inflammation. So if it is elevated more than 10 mg per liter, then it is an indication of acute bacterial infection. Infection can activate systematic inflammatory response syndrome and release the cytokines and activates the coagulation cascades which contributes to the sepsis. The activation of systematic inflammatory response will contribute to the release of stress hormones such as adrenaline, noradrenaline, and cortisol by the adrenal gland. This increases the blood glucose level in the body. The increased glucose level will increase the demand for insulin. Furthermore, it leads to the metabolic acidosis in the body. Therefore, the deteriorating patient with the DKA in the case study is at elevated risk of post-operative septic shock because of their metabolism state and immunosuppression which disrupt their wound healing processes after the surgery, resulting in the growth of bacteria and failure of vital organ. Now, for further more information, I'm going to hand over to Apeksha. Thank you so much.
Thank you, Deepika. Hello, I'm Apeksha, and I'll be discussing about two diagnostic results and related to the underlying pathophysiology. First one is urine analysis. The surgery triggered Miss Casey's stress hormone like cortisol, growth hormone, and catecholamines, and her being type 1 diabetic led her to the infected wound. Insufficiency of the insulin in her body lead to increased gluconeogenesis and glycogenolysis, where protein catabolism triggered by elevating catecholamines and cortisol levels, which then raise level of gluconeogenic amino acid precursors such as alanine, lactate, and glycerol. The glycogenolysis is stimulated by glucagon, and because of which hyperglycemia occurs, as there is lack of insulin-dependent glucose transport and utilization in peripheral tissues. The body then excreted the glucose through urine. Pathophysiology link for high ketone in urine is the hormone-sensitive lipase is activated by the hormonal imbalance, which decreases insulin and a relative rise in stress hormone, because of which triglycerides break down, releasing free fatty acids. Once the fatty acids reach hepatic mitochondria, the generation of keto acid is boosted, releasing beta-hydroxybutyrate and acetoacetate which will further transform into acetoacetic acid, beta-hydrobutyric acid, and acetone. As a result, those acids are partially eliminated in urine after being filtered by the kidney. Urine is hence concentrated. The second result is high WCC, CRP, and anion gap. Having diabetes has compromised our immune system, which led to slow wound healing and led to infection. In such case, immune system activated the inflammatory response in the body, which resulted in pro-inflammatory cytokines such as interleukin-1 and tumor necrosis factor alpha, and this led to the production of more white blood cells in the body. CRP is an inflammatory protein and plays an important role in inflammation sites by binding to apoptotic cells, inhibiting the assembly of terminal complement components, and promoting the opsonization of apoptic cells. So the number of CRP is high in Mrs. Casey's body. Talking about the high anion gap, when ketone bodies split apart, a lot of hydrogen ions are created, and normally bicarbonate absorbs hydrogen ions. However, due to an excess of hydrogen ions, its ability to buffer is exceeded, and which resulted in anion gap metabolic acidosis in Miss Casey's case. That was all for today from me. Now I would like to call my friend Dilasha for further continuation. Thank you.
Thank you, Apeksha. I'm Dilasha, and I'll be explaining 3 high-priority interventions that will help improve Miss Casey's clinical condition. Based on the given case study, Miss Casey exhibits symptoms consistent with moderate decay and potential post-operative infection. The following are 3 high-priority interventions to improve her clinical condition. First is assess and maintain airway. Ensuring that Miss Casey's airway is clear and that enough oxygen is being given to her is important. Keeping an eye on her and respiratory effort, oxygen saturation, and rate of breathing is necessary to improve her condition. More oxygen should be given to Miss Casey as needed to sustain an oxygen saturation above 92%. The nursing team must stay ready to help with airway management by providing bag masks, ventilation, or intubation if Miss Casey's respiratory condition worsens or impending respiratory failure as directed by the medical team. Second one is track electrolyte imbalances and correct them. In the case study given, electrolyte abnormalities are present in Miss Casey as she has a history of DKA. Focusing on potassium, sodium, and bicarbonate levels when closely monitoring her electrolyte levels is necessary. Nurses must immediately correct any imbalances and follow the instruction of the medical experts. Acute decay and vomiting can cause hypokalemia, which can worsen cardiac conduction problems. Thus, close attention should be paid to potassium levels in her condition. On the basis of the given case study, potassium supplements should be administered with caution while keeping an eye on cardiac and renal function. And the third one is pain management. In the given case study, Miss Casey's crampy lower abdominal pain may be a factor in her discomfort and general clinical status. Using a recognized pain scale, the nature and severity of the pain should be evaluated, and right analgesics should be given to reduce the pain. As a first line of treatment, non-opioid analgesic like paracetamol can be used for Miss Casey for pain management. Nurses are required to work along with the medical staff to choose the best analgesic regimen for her, considering her medical history and any potential side effects. Now I'm going to talk about 2 drugs that can be used in the management of Miss Casey. They are insulin and ceftriaxone. Firstly, I'm going to talk about insulin. Acrapid can be used in management of Miss Casey as it is a fast-acting insulin and used to control hyperglycemia in diabetic ketoacidosis. Acrapid functions similarly to the insulin produced naturally and facilitates the entry of blood glucose into the cells. The signs and side effects of diabetes are reduced by regulating BGL. Additionally, insulin inhibits lipolysis and ketogenesis, which aids in reversing the metabolic acidosis brought by DKA. After injecting it, it will begin to reduce your blood sugar level after 30 minutes later. It is essential to regularly check blood sugar levels to regulate the insulin infusion rate and avoid hypoglycemia. Now I'm going to talk about ceftriaxone. Ceftriaxone has a broad spectrum of activity and can be used in Miss Casey's pain management, as it is used in the management of sepsis or intra-abdominal infections. It works by preventing the formation of the bacterial cell wall, which results in cell death. It is frequently utilized and covers a wide spectrum of gram-positive and gram-negative bacteria. Since ceftriaxone has good tissue penetration and a lengthy health life, a once daily dosage is usually appropriate. However, it is crucial to consider regional patterns of resistance, and the choice of antibiotics should be made in accordance with findings from culture and sensitivity test of the patient. I appreciate your attention today, and this brings us to the end of our presentation. I would like to thank all my team members for their time and efforts in successfully completing the project. Here is the list of references that we use in generating our script for the project. Thank you.